Hi, my name is Carlos Castillo, and I will tell you about my work on low-field cardiac MRI, and how low-field cardiac MRI can be used to revolutionize the assessment of cardiovascular disease.
But first, what is considered as a cardiovascular disease? Cardiovascular diseases are a group of disorders of the heart and blood that lead to a heart attack or stroke. These diseases are the leading cause of death worldwide, and it's estimated that 1 out of 3 of us will die due to one. The problem is that 3 out of 4 of those deaths are in low and middle-income countries. If we look at the map showing the worldwide death rate from cardiovascular diseases, we notice the same pattern. But how does the availability of diagnostic tools, such as MRI, look? Here, we see a crude reality. The regions most affected by these diseases are the ones that are also less able to assess them. But do not lose hope. The recent introduction of high and low-field scanners could greatly increase the accessibility and affordability of cardiac MRI, as they require simpler hardware, lowering the overall cost. Now, how does it look when we use one MRI sequence, decide at a more traditional field strength, like 1.5T, look at 0.55T? The answer is not very good. This is due to the changes in magnetic properties of the tissues and the decreased signal-to-noise ratio experienced at lower field strengths. Nevertheless, we can exploit some of these properties to increase the image quality to be comparable to 1.5T. Some of these are reduced homogeneity artifacts, faster signal recovery, and longer signal decay. To tackle these problems, we used a high-end low-field scanner. As the imaging technique, we opt to do black and bright blood imaging to assess not only the cardiac lumen, but also the vessel walls simultaneously. We use a sequence that does not require breath holding or contrast agents, which are commonly used in clinical practice. We used accelerated acquisitions to decrease the scan time, and we tested this sequence on 12 healthy volunteers and 2 patients with cardiovascular disease. To optimally use the available hardware and exploit the physics at low field, we used MRI simulations to select the best parameters for the acquisition to get a good signal-to-noise ratio and fat saturation. Finally, we also incorporated fast, low-quality images called iNavs before our acquisitions to correct for respiratory motion. This is the heart going up and down during the acquisition. From them, we estimate the respiratory state and use it to estimate non-rate deformation fields for motion-corrected reconstruction. To increase the image quality, we incorporated a final, high-dimensionally patch-based low-rank denoising or HD-PROST to finally obtain a motion-corrected volume. Our sequence can obtain whole heart, black and bright blood images simultaneously in 7 minutes with excellent image quality. The same excellent quality was observed in all healthy volunteers, both for small cardiac structures like the coronary arteries shown at the top row, and the large cardiac vessels shown using a maximum intensity projection on the bottom row. Going back to our original goal, is the image quality of 0.55T comparable to 1.5T? It is. In the top row, we see the results of our 0.55T sequence compared to the corresponding version at 1.5T. We see an excellent agreement between both. But most importantly, we saw similar results in patients with cardiovascular disease at 0.55T when compared to 1.5T. Here, we show at the left results for a patient with thoracic arthropathy and at the right, a patient with aortic valve disease.
I hope I have convinced you of the potential of low-field cardiac MRI to increase the accessibility and affordability of cardiac diagnosis. And let's hope that the world we saw at the beginning of the presentation will look more like this in the future. Thanks for listening.